Hello all, this is Dr. Pavan Yadav here, pulmonologist working at Bangalore Astor RV Hospital. So today with me I have Dr. Shishir Rao, a very good friend of mine. He's working as assistant professor of neurology in neurocritical care as well at Detroit, Michigan, USA. So thank you so much, Shishir, for sparing time for us. And we would be very happy to know your experience of dealing with COVID-19 patients at US and how it has changed your practices. And if anything you have to learn from you, any valuable tips that you can share with us. I'm sure you must have had a lot of new experiences, and we will be very happy to learn those things from you so that it can be implemented here at India, because the pandemic has not been so much in a larger proportion as compared to US, and US has been the hotspot of the ongoing pandemic as of now. So Shishir, over to you. Please enlighten us regarding the situation there and a few learning points for us, please.
Thank you, Pavan. It's been a long time since my experience in the United States, particularly with COVID, limited to neurocritical care, but I have been working in the neuro ICU for some time now, and I have gotten a good share of experience with these severely, or should I say, more severe COVID patients that require intensive care treatment. So again, I'd like to kind of go over my experience that I have in the last couple of months in the ICU. I'm going to show some slides, some numbers at the beginning. And let's start with, there you go. All right, so main thing to understand is that COVID-19 is very infective. A lot of patients around the world have become positive. There are about 4.5 million cases around the world, and about a third of these patients are in the United States. And out of these, more than 87,000 cases of deaths have been seen in the United States. And in the United States particularly, we have more than 4,100 cases per million population. Why is this important? We know that there are about 4.5 million cases that have been reported, but is this accurate? We are not sure. I feel that most of the places do not have adequate testing, and large number of cases are underreported. And this is also important because PCR that is validated for COVID-19 has only about 70% sensitivity. So what that means is out of 100 patients that are tested for COVID, only 70 patients come back positive for COVID, and the rest are called false negatives. Also, we should know that the nasal swab that doesn't get that, then there could be false negatives there as well. So it's important to know that these patients and the numbers that have been reported around the world could be largely underreported. So going over to the history, we know that we've had such large pandemics in the past as well. In around 1918-1919, there was a pandemic of H1N1 that had over 500 million patients around the world. That is about 1/3 of the world's population. There were around 50 million deaths at the time. The important thing to know at that time was there was no vaccine, no antibiotics for secondary bacterial infection, and also the main treatment that was effective in most of these patients was just non-pharmaceutical interventions like isolation, quarantine, good personal hygiene, disinfectants, and limiting public gatherings, similar to what we're doing right now. This is a nice study that came out in 2007 about the importance of non-pharmaceutical interventions in the management of pandemics. If you look at the 4 cities that have been reported in this particular um, figure, you see the one on the top left is for St. Louis, and the other 3 are New York City, Denver, and Pittsburgh. What we see is the cities that instituted early social isolation, particularly St. Louis on the top left. We see that the curve flattened early. So it's important to do social isolation early and keep that going. If you see, there was a gap in social isolation, particularly school closures and public ban of gatherings, and you see the second kind of peak that happened around December. And then again, everything was reinstituted, and then the curve flattened again. If you look at other curves, New York, Denver, and Pittsburgh has higher peak that happened in the beginning. That was because the cities took a long time to start social isolation. Looking at numbers for Michigan now, we see that the number of cases that started around mid-March peaked early, and within a month, we had a lot of cases, even going up to 2,000 cases within one day. Again, we see that the curve kind of flattened and the number of positive cases have kind of reduced after mid-April. And this could also be because a lot of patients started coming early. And now in the last few days, we have started seeing less cases. Michigan has also approved even patients who have mild symptoms to get tested. So the number of cases that we are going to see in the next few days is possibly going to go up. The next slide shows some figures about the patients that we are seeing in Michigan. One thing to note is these are the number of fatalities, and we have age ranging from 5 to 107. The important other number is the case fatality rate that has been about 10% in Michigan. From prior studies that we know, we have a number ranging anywhere from 3 to 5% or a little higher around the world. But in the United States, the current numbers are showing about 6% according to the Johns Hopkins website. We also see that the number of patients that come back positive are higher in females, while the number of male patients that have disease is higher. Next number to note that is important for the rest of the world is the number of patients that are deceased that are over 60 years old. And we see a higher number, which is about 87% of patients were older than 60 years, if you look at the table at the bottom right. So these are the numbers that I have from the prior studies and currently that is going on in Michigan. Over to you, Pavan.
Okay. So Shishir, can you tell us that how this experience with the pandemic changed your practices, because there must have been certain set of rules and practices which you must have been practicing for certain time. Now with the introduction of this new infection or the new pandemic into the system, there must have been a lot of changes that must have undergone in your policies and in your practice as such, right? So can you enlighten us regarding the changes which were brought into your practices in the post or in the present COVID era?
Definitely. So, primarily trained in neurocritical care are traumatic brain injury, subarachnoid hemorrhage, large ischemic strokes with herniation, intracerebral hemorrhage, status epilepticus. Those are the main patients that we treat. And most of them have some kind of systemic involvement, lung involvement, so they're intubated, we manage ventilators, we do blood pressure controls, renal failure. So those are typical patients that I see on a day-to-day basis in my neurocritical care. Some of the other procedures that we have done is just some basics and some occasional complex ventilator managements, airway management, bronchoscopies as needed. Of course, when it comes to brain, we have to deal with brain herniations and other complex neurosurgical patients, I must say. With COVID, we are seeing more neurological manifestations. Even though it could be subtle, there are a few that require neurocritical care management as well. There have been studies which have showed loss of taste, smell, ataxia, more convulsions, which are new onset seizures without any known history, has been seen in some of these patients as well. Large multivessel ischemic strokes have also been seen. And this is important because we have seen a lot of patients have micro and macro thrombi throughout the body. I'm going to talk about that in the next few slides as well, but it's important to know that strokes have been seen in a lot of these patients. And there are numerous publications that are coming out which show that patients are having large vessel strokes related to COVID. So next important aspect about managing patients is how to triage patients. Unfortunately, we only have a few beds in the hospital, few critical care beds, and not every patient can be admitted in a hospital. So we need to figure out who needs admission and to what kind of level of care do they need. So next, what we are seeing is patients can come in a wide spectrum. Mild symptoms, they could be treated at home. They just need supportive care and isolation. This is an X-ray or kind of normal looking X-ray in a patient who had COVID. While on the other extreme, we have moderate to severe symptoms that require hospital, possibly even a critical care admission in an ICU setting. Some of these patients require empiric antibiotics until cultures are available, because you don't want to blame everything on COVID until the results come back. So you want to treat them broadly and then figure out what comes back. If COVID comes back, then and other cultures come back negative, then you can stop these antibiotics. Supportive care is one of the most important things that we're doing as of now, because there is no FDA approved medication available to treat COVID as of now. Other medications are under trial. I'll talk about that in a bit. And there have been compassionate usage of some medications, plasma, and then again, I'm going to talk about that in some time.
So Shishir, I have
Yes.
a question. So what is your threshold for getting a CT thorax done? Because I'm told many patients are coming without any respiratory symptoms per se, and eventually turning out to be COVID positive later in time. So what is your threshold for getting a CT thorax done? Of course, in not so bad chest X-rays, like the X-ray which you have displayed over there. So do you go ahead and get CT thorax for everybody, or is it like somebody who's little hypoxic, little tachypneic, and mild respiratory symptoms should be there? Or is it like a specific group of patients, like who are maybe immunocompromised, etc., in whom you would prefer getting CT thorax, or is it like you're more liberal with getting the scans done in this group of patients?
An excellent question is X-rays are more easier to obtain. CT scans are harder, not only because of the patients not being stable, but it's also because the cleaning techniques for CT scanners are different. Once you have a COVID patient, it takes about 3 hours for the room to be cleaned in case there is a COVID patient that goes into the CT scan. Mm-hmm. The main threshold for these patients, particularly in patients who are not as sick, is, like you mentioned, patients who have severe hypoxemia, chest X-ray showing some infiltrates, and if there is any significant tachycardia that you're thinking of pulmonary embolism that you need to get further scans. And those are the main patients that we get a CT scan. We don't get it routinely. We do get it, on some special circumstances, just because of the severity of these patients. Some of these sick patients require multiple pressors. They're being managed on ventilators with high peak pressures, high, peak requirements. So it's hard to make them travel all the way from our ICU down to the CT scan, get that when the yield of those CT scans is lower, not because not because it doesn't show anything. It's mostly because what are you going to do different with the management? So we do get it, not often, but we do get it on some case-to-case basis, particularly chest X-ray not showing much, but patients are clinically deteriorating. Those are the ones that we get CT scan on.
Okay, sure.
Does that answer your question?
Yeah, absolutely. Thank you.
Okay. All right. So next group of patients are asymptomatic patients. This forms a large chunk of patients that we are seeing around, walking around without any symptoms, and these are the ones who are actually troublesome, I must say, to the people around, because they are the ones, without knowing that they are having COVID, or they're transmitting the virus around to other people. This was a study that came out from China, and they had about 25 patients, and they noticed that the younger patients, so the average age for these patients was about 42. And if you look at the scans, you do see, this is a CT scan of a patient, they did see some ground glass opacities. Majority of these patients are actually, since they're seeing asymptomatic patients, all the patients did not have any kind of symptoms. The CT scan on the right, though, shows that the ground glass opacity is actually improved within short duration. Usually these was anywhere between 10 to 14 days. But what they are noticing is, even if the CT scan is showing some ground glass opacities, they may not have any symptoms. Some of these patients that we have seen in the ICU setting actually present with very low oxygenation saturations on their pulse ox, but they don't have much symptoms as well. And suddenly they have, worsening respiratory status, and it's hard to say that if they're even walking with such low saturations. All right. So next question. Do you have?
Yeah. So what are your testing criteria? So one was, of course, a CT scan in patients who are suspicious of having some lung condition, lung involvement. So what are your testing criteria? Like, what are the different modality of tests which are available, and then when do you use them? How do you utilize them? And so please enlighten us regarding the testing criteria, Shishir.
Right. So COVID testing is mostly by PCR as of now. And what we have in Michigan is that we have about 15,000 tests that are being done in Michigan on a daily basis. And the criteria has been expanded. Earlier, when COVID had just started, we saw that only the patients that had severe disease or healthcare workers were getting tested. But now, even just because the numbers are going down and the availability of tests has been better, we do have patients with mild symptoms, and every essential worker working in hospital or other healthcare systems or anywhere else that have to go to work are getting tested. On an average, we have about 2,800 to 300,000 tests that are being done in the US. So this is a large number of tests. But what we are seeing is, if it's only about 300,000 tests per day in the US, it probably takes about 6 years in the US to test everyone once. And that's a long time. We don't have that time. So the question is, who needs to get tested? And, is it only for mild symptoms? Everyone needs to get tested before getting back to work. So it's a question that we don't have an answer to, and we'll probably get to know about it over time.
Okay.
So The next the next testing that's available is the antibody test. One problem with the antibody test is that it has, the FDA has not yet completely approved it. There are over 200 tests that are available, so it's not been validated. It could help, we don't know, but what we are thinking is it could help to know whether anyone has current or prior infection if they've not been symptomatic. And it could also help if you're thinking of convalescent plasma. So this is one of the treatment strategies that I'm going to talk about in the next couple of slides, but it could help as well.
Actually, if I can
Yes.
ask one question here. So a lot of interesting questions regarding something called as immunity passport or something.
Right.
When they say if you do this antibody testing, if the IgG levels are high, and then whether that should be the criteria to allow such people to freely go around and start the regular work and jobs, so that they can bring up the economy. Rest of the people who are more vulnerable can stay inside and locked up inside their houses, because in India we are still at this stage wherein we have to decide whether we really need to release a lockdown, when to do that. So this is one such interesting topic, along with herd immunity as well. So any idea, any knowledge regarding that?
Yes, I have read about it recently about about using these studies to say whether people going around are safe. One problem with that is that we don't know what is the risk of reinfection. And if you have people walking around thinking that they have the IgG, which is the long-term immunoglobulin that is present, and they feel that they are safe, and we don't know the risk of reinfection in these patients or in these people who are walking around, and they could still get infected again. So unless we get clear kind of research into the reinfection rates with this COVID, we cannot say for sure. At least I don't feel comfortable saying that patients who have had disease once, or if for some reason they were asymptomatic and they get the IgGs, but these patients or these people could have two problems. One is they could get reinfected. The other problem is if they continue to be asymptomatic and we don't test them again with PCR, we don't know if they could infect people around them as well. From my experience, I can tell you that, we always talk about patients need to be quarantined for 14 days, 28 days. I have patients that I have treated with PCRs that came back positive on day one of admission, intubated for a prolonged time. This is, when I say prolonged time, we are close to a month, and then retested, and they're still positive for PCR. So how do you know? We don't know. We don't have clear answers to how long patients can be positive for PCR. And you could have people who are PCR positive once, and then the second time it could be negative. But again, the sensitivities of this test is only 70%. So it's hard to say who is actually immune, and if at all they are immune to getting the COVID again.
Okay.
One other point that I would like to mention here, particularly in a hospital setting, if you have patients that you're testing for PCR antibody tests and you're waiting for the test results, and our turnaround time has improved dramatically. And earlier we used to take 7 to 10 days to get test results back when we had to send it to the state. But now we have in-house testing and we get it within a couple of hours, so within a short time. So, but still, you could have patients that come back negative, but you have a very strong clinical suspicion that these patients could have COVID. In these patients, the things that you could check are, markers of inflammation. LDH has been, shown to be high in these patients. D-dimer, fibrinogen, ferritin, C-reactive protein. These are the ones that we typically measure in patients, and if they're in-house in the hospital, we check them once in a few days to see what their titers are. If they're getting worse, then probably clinically they're going to get worse as well. So that could be helpful to kind of track patients and then figure out who needs admission, what kind of admission, what kind of treatment you could do, and other supportive measures, and even to say these patients are PCR negative, but they're actually could be, could have COVID as well.
Okay.
Okay. So next, I'm going to just briefly talk about a nice paper from Virginia, and they always that it's mostly for management of patients. And one thing that, again, this is more of a pathophysiology and pathogenesis of the COVID, is to understand that the viral replication happens within the first few days. So if you notice this, there is a short incubation period. Patients are symptomatic from viral replication, but again, in the future, what we're seeing after a few days, after about 10, 12 days, the patients who get really sick are the ones who have immune dysregulation. So this is the theory based on certain treatments that are being proposed for most of these severe COVID patients. If you see the next part of the graph, you'll see the ground glass capacities that actually gets worse as the number of days are higher, from the initial incubation period. So once the immune dysregulation kicks in, ground gas capacities gets worse, and that's when you see progressive hypoxia as well. Why is this important? So it depends on how the patients present to the hospital, in what stage, for you to decide what kind of treatment could help these patients. Again, there is no clear-cut guidelines to say you can treat patients with antivirals or anti-inflammatory medications. But if you understand what stage of the disease the patient presents to you with, you could decide, what could help, and you could kind of frame your treatment plan according to each patient's presentation. If the patient presents within the first few days, antiviral treatment, whatever could come out in the future, could help. But once they start the later phase, which is more because of the immune dysregulation, that's when you want to start anti-inflammatory treatment, which is probably a little bit of immune suppressive treatment. Again, this is a second part of the figure, which shows the patients are doing well during the incubation and mildly symptomatic stage. If they go into the early pulmonary or the late pulmonary stage, these are the ones that are more sick. Their oxygen saturations are going down, their inflammation is going up, and they could benefit from some kind of anti-inflammatory treatment. Okay, so over to you, Pavan.
So what are the different treatment protocols you're following, Shishir? I am just definitely understanding that you have different groups of patients, like mild, moderate, severe, and most of the treatment has been supportive and symptomatic, definitely.
Right.
So do you have any specific treatment, or are you following any specific treatment protocol? You are mentioning about the antivirals and anti-inflammatory agents as well. So what are your protocols, and how are you approaching these patients? Definitely when an actual treatment is required and you're looking into starting them on any specific treatment.
Okay. That's the next phase of managing these patients with COVID. Treatment protocols. So we have patients coming in. What do we do for them? New data is coming up, so it's hard to kind of treat patients the same way throughout this COVID pandemic. So it's always good to refresh and talk to other people, get other ideas. But what we know so far is there are tons of patients who are asymptomatic or who have mild symptoms. So supportive care is the main thing to do in these patients. Mm-hmm. The next comes who are at risk to have worsening symptoms. And who are the patients who require more treatment And so far, what we know is patients who are in an ICU setting who require ventilator support, their oxygen requirements are getting worse. They see chest X-ray or CT scan is showing multifocal pneumonia, worsening infiltrates, or patients who have chronic lung disease, chronic heart disease, or patients who are older. So these are the ones who are at high risk for getting worse, and we have to do something more than just supportive care. Is there anything available? As of now, there's no FDA treatment, the approved treatment that is available. But there are multiple drugs that are being studied throughout the world to see if any one specific medication is the magic treatment. But we don't know that yet. Initially, along with supportive care, we started patients on multiple treatment options. Hydroxychloroquine was shown to be effective in vitro, and it was implemented in most part of the, in most hospitals around the world, including the United States. But this recent studies are coming out which show that hydroxychloroquine may not be as effective in treating COVID. So it can also cause cardiac arrhythmias due to QT prolongation. So that's a concern as well. Next medication that's available and is under limelight as of now is remdesivir. It was recently approved for emergency use authorization, and that was by FDA. So remdesivir is available. Again, this is mostly on a trial basis. A lot of trials are being conducted everywhere to see if this is actually if this medication actually is efficacious in COVID patients. There are a lot of retrospective studies, but to bring a drug to a market completely, you have to have some kind of prospective trials which are showing promising results. The other medications that are available then that are being tried is tocilizumab. And one last treatment option is convalescent plasma. So this is plasma of patients that recovered from COVID, and they have the IgG, and this is supposed to help. So again, there are trials going on to see if plasma of these patients would help more sick patients. So we'll see what it shows in the future. We should never forget that supporting measures are important in treating patients. Like I mentioned, inflammation is one of the main causes of worsening of COVID patients in the first couple of weeks, and steroids could be helpful. So we do use steroids in our patients as well. One thing that has been studied, and mostly retrospective studies have shown that there are a lot of patients who have micro and macrovascular thrombosis. And one important aspect is systemic anticoagulation in these patients. And some of these patients really need full dose anticoagulation to actually prevent from worsening. And there were studies that were done in China and other parts of US, which came out recently, which showed that patients actually had better outcomes if they were treated with systemic anticoagulation, particularly in patients who have significantly elevated D-dimer, because it is a sign of patient who has extensive thrombosis. So this is something to consider in patients who have severe COVID disease requiring particularly ICU management, and you could use that elsewhere as well.
Shishir, one second. If you can go
Yes.
back to the last slide, please.
Yes. If I can, let me see. There you go.
So how much steroids do you really use, and how long?
So again, the dosage of steroid is being studied, and different protocols have different dosage of steroids. The ones that we use is based on the body weight. Usually about a milligram per kg of oral prednisone or equivalent of IV should be, should be sufficient in most of the patients. In some of the patients, actually, if I go back to immune dysregulation and macrophage activation syndrome. So this again was from Virginia, and they want, or they prefer that these patients who are going into macrophage activation syndrome receive much higher doses of steroids, which could be up to 120 milligrams of prednisone or methylprednisone 2 to 3 times a day. So it's significantly higher than your average dose of steroid that is being considered for other systemic problems.
Yes. And
Any other questions?
so,
Yes.
okay. So how long do you try any other modalities before considering intubating these patients, like NRBM or NIV or HFNC, etc.?
So our protocol typically uses, non-invasive positive pressures and high flow nasal cannulas are being used. One of the main problems that was considered early on in the disease was how significant is aerosolization with these techniques, and not much has been known, but we still are very cautious about using these. It's better to go into these before considering intubating patients, because there were studies that came out recently which showed that intubation or intubating patients with severe COVID by itself had poor prognosis. So these studies showed that patients who were just on NIPPV or high flow nasal cannula, they actually had better outcomes before they went on to get intubated. So how long do we try? So typically, if the oxygen requirements are getting worse, there is no clear timeline that we are following. What we know is if the oxygen requirements are getting worse and if the PO2 on the same settings are getting worse, and there is more respiratory distress, the patients are not comfortable, that's when we decide to put patients on ventilator and intubate them.
So there was a school of thought where they advised to go for early intubation to prevent the aerosol generation and being the risk for the healthcare professionals. So
Right.
Obviously you do try other modalities before considering intubation. Okay.
Exactly.
Yeah. And how early do you consider proning in
Um,
patients with severe desaturation and bad lungs?
So let me go back to your first question again. The earlier school of thought was early intubation, but now people are thinking that early intubation could make things worse as well. So there's different schools of thoughts about that. Early intubation reduces the risk, definitely, of aerosolization and exposure to healthcare professionals, but early intubation could also mean that you're causing more barotrauma, more problems with ventilator associated kind of barotrauma problems, and that could by itself make things worse from a patient who has just plain multifocal pneumonia to go into ARDS picture. So that's those are different kinds of schools of thoughts, but we don't know what is accurate yet. Eventually in the next few weeks to months, I guess we will know what is better, and we can kind of tailor our treatment based on that, those recommendations. And yes,
Proning.
I forgot your question, sorry.
Proning.
Proning, early proning. What we institute in our institution is if their ventilator settings are getting worse, even minimally higher requirements, proning has shown to be better. And we have seen significant improvement in patients who actually were proned early. And again, what I feel is this COVID is going to take its natural course. So what we need to do is, unless we get kind of a treatment which works really well for COVID and decreases the length of stay, decreases the length of severity of these patients during this later phase, we have to just let this natural course complete. And the way that we are doing that is by giving kind of supportive management. Proning helps improve the oxygenation. proning helps significantly in these patients. And just doing 16 hours of proning, just the ARDS protocol, where the trial that came out about 16 hours of proning with 8 hours of supine positioning actually really works in these patients, and their oxygenation improves within within first 1 to 2 days, and we usually do it for about 5 days, and by then their oxygenation gets better. We sometimes see that these patients do have their second relapse, and they may need a second kind of stretch of proning, but overall, it helps kind of go through the phase where these patients are getting sick, and it helps to kind of give time for the actual natural course of this COVID disease to kind of progress.
Any experience with ECMO, Shishir? We were discussing it earlier briefly.
Right. Not for me. We in my institute we don't have ECMO, but in my neighboring hospital there are ECMOs, but it's just because of the number of people involved and the resources that is utilized and the shortage of ECMO that's available. It's provided to severe patients, younger patients who likely have better outcomes, and it's usually instituted for on a case-to-case basis. The advantage of being on ECMO is all these patients require anticoagulation, and maybe that helps improve the outcomes as well. So that's something to think of.
So last two questions regarding this treatment protocol. So are you doing enough number of bronchoscopies as earlier times, or is it like they have come down significantly because of the risk of resolution?
Definitely gone down. We used to do bronchoscopies, particularly in an ICU setting. We used to do it on a regular basis, but now intubations, even for intubations, we have to call people who have full gear, full pappers, and anesthesia usually does our intubations. And even bronchoscopies, just because of the amount of exposure that patients could get, or healthcare professionals could get, we have decreased them significantly, even if at all it's being done, particularly in an ICU setting. And I'm going to talk about outpatient care, that things changed in the future slides, but most of the outpatient bronchoscopies have been stopped as well.
So I'm presuming you're not using nebulization also, mostly MDIs?
MDIs, correct, exactly.
Okay, Shishir, we can move on for the next topic, probably organization.
Okay, so what changed in the hospital organization is to understand that when this COVID started, it was causing more of exposure risk to majority of the healthcare workers. And also there was significant risk of exposing other people if there was more people, more patients within a small area. So most of the non-emergent surgeries and outpatient services were withheld in the United States. Most of the hospitals initiated something called as all hands on deck. So whoever was involved in patient care, to whatever their expertise is, they were called on a voluntary basis to come and help in the hospital setting, just because of the peak of the number of patients that were seen in the beginning. And this also helped with other kind of groups that were very busy, particularly medical ICU, any of the ICUs, emergency rooms. These were the ones which were flooded with patients, and the hospitals required all the help that they could get. One of the main important topics to cover is how to improve or increase testing capabilities. That is very important to understand who is at, what is the risk of exposure among healthcare workers. And again, it's not just important to test patients, it's also important to have enough PPEs available, because without these, there is significantly increased risk of exposure among healthcare workers, and the appropriate PPEs are required depending on what level of care they are providing. Uh, One other thing that has changed in the hospital system is we are not seeing as many patients with non-corona or non-COVID symptoms. So why is that? There was a study that came out recently from northern Italy, which looked at the number of patients who presented with acute coronary syndrome. And the study showed that there was significantly lower number of patients who presented with ACS during the time of COVID for the 2 months that they studied. And if you look at the numbers, during the study period, there were about 13 patients, 13 admissions per day, while it used to be about 18 admissions in the earlier part of the year and about 18.9, that's 19 patients per day during the previous part of the year. One thing to note is that because of late presentation of these emergency or more severe conditions, patients are presenting more sick to the hospital because of the underlying condition, like ACS. Patients used to present with even mild chest discomfort. Now they are, more severe and having more worsened symptoms when they present to the hospital. So the outcomes are going to be worse in this situation. So next topic of discussion is when to resume all all services that have been halted during this COVID. There is one important thing to consider is how well the local authorities are able to curb the spread of disease. Social distancing is important, but we need to understand that testing is very important before considering extensive reopening or resuming these elective surgeries, outpatient clinics. So one important thing to consider is, has the curve been flattened in that area? And this is something to understand, and it needs to be very local. Some higher level, or at a state level or a country level, it's very hard to figure out what a local area is doing with response to COVID. There is joint statement that was released by 4 main associations: the American College of Surgeons, American Society of Anesthesiologists, Association of Perioperative Registered Nurses, and American Hospital Association. So this is a nice guideline to say what would be ideal timing to resume elective surgeries after the COVID-19 pandemic. One other thing to consider is quarantining patients who are supposed to have an elective surgery for about 14 days. One aspect to note is these patients should self-monitor about 7 days prior to surgery. Ideally, you want to have a COVID PCR testing about 3 days before surgery, just so that you can know what to do with these patients. If they turn out to be positive, reevaluating time about the timing of the surgery. If they're negative, of course, the patients need to monitor themselves for COVID symptoms. For emergency surgeries, you have to do these surgeries. And one thing to do is to just treat them like they have COVID, and just take all the safety precautions that's necessary for healthcare workers. Why is this important? One study that came out in China, this was early on during the COVID, was when these elective surgeries were still being done. And what they noted was that within these 34 patients that they studied, the number of cases that got dyspneic requiring ICU was about 15 patients, about 44% of these the patients. and and 7 of these patients actually died. So, which is a mortality rate of 21%. It's actually higher than the mortality rate that has been seen among patients who get COVID. So, is this related to the stress of the surgery? Most of these patients required prolonged surgeries, but there were quite a few patients who required shorter surgeries as well. But if we know that these patients did not have COVID symptoms when they were taken to the OR, but they developed symptoms within a couple of days after the surgery. So, thing to note is, doing elective procedures in these patients may not be good for the patients and may not be ideal for the healthcare workers as well. Pawan?
Yeah. So, Shishir, it has been exhaustive and comprehensive coverage of this topic. Thank you so much for all the detailed evaluation and giving us a lot of crisp and to the point messages. So, any last points for us to conclude and any valuable take home messages for us?
All right, so take home message. The main thing to understand what I feel is important is that globally, there's going to be a significant number of people who are going to contract this virus. So be on the lookout for infected patients in your practice. Definitely, consider that every patient could be COVID. So take the precautions that you need. One other aspect is this is something new, a new kind of learning experience for every healthcare worker, everyone around. There's a lot to learn from someone's success, someone's failure, but just take this opportunity to learn something which you've never done before. So go out of your comfort zones. Like I mentioned earlier, we used to have certain vent patients requiring all the minimal support. Now we are managing patients who have different modes of ventilation. We've prone patients within my short exposure in the critical care. We have done a lot more respiratory care, airway, and lung management. And these patients are really sick. So you have to step out of your comfort zone to treat these patients. Main other things is protect yourself. That's very important among healthcare workers and rest of the public as well. One main aspect is follow the local guidelines that is making sure that the spread of this virus is slower, and follow your social distancing measures that is being instituted by your healthcare authorities.
So Shishir, you think you have got probably a crash course in pulmonology and critical care in the COVID era?
Oh, definitely. Yes. So most of the uh, teaching is done by the patients anyway. And every patient is very different when it comes to critical care. So what I have learned within the past couple of months with respect to respiratory management, lung and airway management has been remarkable. So I enjoyed working in the critical care within the last couple of months. The patients who have been more sick and patients who have been treated, and there are quite a few patients who actually get treated well and then leave the hospital, get extubated, leave the hospital. And it is fruitful to see these patients do well in spite of having such severe disease, which has very high mortality.
Okay. So it's been one great learning experience for all of us. I think we never expected and we never could have had, any learning or preparation for this sort of a pandemic. And some of us are ahead of the curve, and we are here at India has a lot of opportunities to learn from others, and we are very thankful from people, from our friends from the West, to help us in learning these things, and probably will be in a better situation to handle from all the learnings that we can do from the West. So thank you, Shishir. It's been a pleasure for your time, and then putting this PPT together and spending time to explain things to us. Thank you so much. Probably we'll get back to you for a few more learning points in the future as well. So thank you, Shishir. Thank you so much.
Thank you, Pavan. It was great to give this presentation and lecture. One of the, there's so much learning to do about this new disease, and every day there's new articles, there's new publications that's coming out. And what I feel is we have learned from, people who started having this disease before us, and different parts of the world can benefit from the experience of other areas, other parts of the world, like United States. What I feel is, India has a lot of cases, and everyone is scared to see what is going to happen in the near future. And understanding how to treat these sick patients from the experience of others could help, and could make the outcomes of these patients better, hopefully. So we will see what's going to happen.
Okay, I think Shishir will stop there. Thank you so much, Shishir.
Okay. Thank you.